This is a good lecture, in my opinion, and I think the lab is fun. You guys will zip around in wheelchairs today. Um, all right. Okay, so seating and wheeled mobility. Okay, so wheeled mobility can be a bunch of different things, right? It could be walker, a manual wheelchair, a power wheelchair, a scooter. Um, you know, a, the wrong device. So complications of a poor seating system. We'll go through all these, but the wrong device for an individual can be not only uncomfortable, but it could also be unsafe, right, or deadly. Um, could also be a waste of insurance money, out of pocket cost. Patients are usually stuck with their mobility devices for a long time, unless, of course, they have a decline in functioning and their doctor writes a script and they have the justification to get a more advanced device, which we do see. But typically for people um, whose functional status stays the same, they have the same chair for 10 years. So things wear down, they need things adjusted. So we're gonna get into that a little bit today. So complications of a poor seating system, I'm sure we could think of more than what's on here, but pressure injuries are a big one, right? Now we say pressure injuries instead of like pressure sores. We're kind of like getting away from that. Um, or pressure wounds. So pressure injuries in general, shoulder dysfunction. Someone that's shoulder dysfunction can occur not only for someone with a manual wheelchair and just putting a lot of stress on their shoulders, but also someone not using a walker appropriately, right? Progressive, meaning worsening, scoliosis or kyphosis, pain, hip dislocation, decreased respiratory function, difficulty with propulsion. Propulsion is how we maneuver the wheelchair. Okay, so it's you're self-propelling the wheelchair. Okay, so propulsion would be, the individual moving those wheels, and difficulty functioning in the environment. All right, so when it comes to deciding what wheelchair to get, there it's pretty much the responsibility of a seating team member, okay? And that could be a bunch of different individuals, okay? So not only is the client involved, but also the family or the caregivers, right? Therapists, so OT, OTA, PT, PTA, the ATP, right? We talked about ATPs, the assistive technology professional, okay? Who certifies ATPs again? Anyone remember what the organization is called? The acronym? Close, RESNA. Yeah. Yeah, so RESNA certifies ATPs and seating and mobility specialists, okay? Um, so ATPs come into play here and also the supplier or vendor itself, okay? So per Medicare, suppliers who work with or distribute complex, those real tricked out power wheelchairs, um, they are required to have ATP certifications. Okay. So if you ever had an interest in working for Buffalo Wheelchair or like any of these other assistive technology companies or vendors, you would need your ATP credentials. Okay. They want to make sure everyone um, you know, has the knowledge to do what's right by the patient. So yeah, no need to memorize this chart, but this just gives you an idea of different things that go into consideration when picking a chair or a seating device. All right, so seating evaluation goals. Okay, You want to make sure that the patient has adequate support. You want to accommodate fixed asymmetries. Okay, so say they have, say they're a little bit contracted, right? Kind of stuck in one position. You'll see those a lot in nursing homes, right? These long-term care residents that just look so uncomfortable in their basic manual wheelchair that wasn't fitted to them. They're just like, they look miserable, right? Um, that's something that's super beneficial when patients have these asymmetries or they're just contracted, don't have much range of motion. It's really nice to be able to get them their own custom chair. Of course, you want the chair to promote stability, mobility, adequate pressure redistribution, and comfort, right? Make it so that they can easily shift their weight to reduce, the pressure on their butt, on their back, on any of their extremities. And integration into mobility related activities of daily living, the MREDLs. Okay. So, who can complete a seating evaluation? Typically, OTs, PTs, OTAs, PTAs. Okay. This is our realm here. We will get it. I'm pretty sure it's a little more in depth in this lecture, but we're always going to do that in collaboration with the ATP as well, right? You're typically going to go through a vendor to order a wheelchair for a client if necessary. And as I said in a previous lecture when we were talking about ATPs, they know what paperwork, what terminology is necessary to document to justify that chair for that patient, right? They are ATPs are. I've never had an ATP say, get them the crappy chair. They always want like the best chair. They're always saying like, oh man, like he would do like you go to the ATP with the concerns that you have. They see the patient with you and they say, oh, what about this? We have this. Oh, check this out, right? They have pictures of things that they know are available, and that's why it's nice to have a relationship with ATPs in the area, just because they can provide a lot of insight as to new things that are available that you may not have known about. But yeah, the initial evaluation is typically done by you, and then the ATP supports that, right?
So apparently,
Yeah.
they just passed, or it's part of like this legislation that they passed,
Uh huh.
at all state park locations, they now have ATV wheelchairs
Oh.
available for their like anyone. You can get them for free, and
Yeah.
basically like the park rangers bring it straight to you. They teach you how to use it. So I'm wondering if now their park rangers are certified.
That's interesting.
I'll have to look more into it.
That's really cool. Yeah.
Makes me
Nice.
wonder now.
That's good to know. So referral. So if you don't have the patient initially, right? They may be referred to therapy for the seating evaluation. Okay. If you're already seeing the patient, you don't need a doctor's approval to check out their chair, right? You would evaluate the patient and then tell the doctor this is what they need. I need you to write a script for A, B, and C. The ATP looks at the script and says that's exactly what we need for the insurance, and yeah. So the evaluation, you're of course going to look at their medical status, their history, the current technology they're using, the environments of use, when they're going to be using, when and where they're going to be using the chair, how often, the client support system, current and desired levels of performance, body systems and structures that need to be supported, and also skills and function with current and future system. Okay, so equipment recommendation, trial, and selection. Okay, so sometimes, actually, quite often, and I can only speak to this as far as the home and a nursing facility, but typically they can give an ATP, or like the wheelchair vendor can show the patient an example of what they'd be looking at, right? Like not only showing them on paper what their chair may look like, but let them ride around in, a loaner chair, right? To give them a feel for it. Um, you know, it allows obviously the client and their families, caregivers, to make the decision on whether or not it's something they want. Um, Especially if the chair is an out of pocket cost. These wheelchairs can cost $100,000, truly. So discussing the options as far as, what, what's the most functional, but also what's the most realistic in terms of budget. Okay, so we did talk about funding a little bit. Coverage criteria. So that's making sure that the right things are documented, basically, to justify the need for a specific chair or a specific, attachment for a chair. So typically, what happens is you see the patient, you recommend a chair to them. The ATP says, this looks good. We'll make sure we get this through insurance. The only thing the patient needs to do is see the doctor face to face. And once in the appointment, the doctor will sign off. And, I've never had a doctor refuse our expertise as far as wheelchair fittings. So components of a seating evaluation: preparing the product, of course. The vendor then comes in, fits the patient, trains them on using it. There's also follow-up maintenance and repair. So here's a contact number in case you have issues with the battery or whatever.
What does ATP stand for again?
Assistive Technology Professional or Personnel. All right, so pelvic positioning. This is important to consider when, looking at a patient in their wheelchair, okay? So neutral pelvic position is ideal for full functional movement, okay? Anterior pelvic tilt, which is pictured in the middle, that's when the top of the pelvis is tilted forward or anteriorly, okay? And it causes that lordosis of the lumbar spine. Posterior pelvic tilt is the opposite. So the bottom of the pelvis is tilted backward. And it often comes with, slouch sitting with a forward head position. Okay. So manual wheelchairs, okay? So manual wheelchairs are just that. There's no power component to it. So transport chair is pictured at the top there. And those are the chairs that can easily be folded up, put in the back seat or the trunk. The purpose of that is to transport the patient from point A to point B. It's not intended for the patient to scoot themselves through town in, okay? If you ever see someone doing that, they're just not using it appropriately. Probably not safe, definitely not comfortable. But it's meant for temporary transport, okay? Getting grandma from the doctor's parking lot to the office and back, okay? Whereas a manual standard wheelchair, that is, for people that do spend a lot of their time in the wheelchair. Now, I know I have it labeled manual wheelchairs, but you're gonna hear manual wheelchair for the guy on the bottom, okay? Transport chair is also manual, but when I say manual, I'm referring to the bottom guy. So manual wheelchairs usually have removable or swing away armrests, okay? And they usually also have removable, adjustable leg rests, okay? Some of the leg rests might elevate, but usually, they're adjustable to some degree. Any questions about the two of these? Now, both of these come in bariatric sizes too, right? So if you have a patient over the weight threshold, 300 pounds, there are wider, sturdier versions. Um, all right. So, also for manual wheelchairs, actually, I'm just noticing. I actually, where I have dependent there, cross that off because actually that's the next slide. The next slide should say dependent. So this slide does not show dependent manual wheelchairs. Dependent would be it relies on the caregiver to push, right? Sorry about that. So anyway, these are just other examples of manual wheelchairs. Okay, there's lightweight and ultra lightweight. You know, individuals that benefit from these are usually full-time wheelchair users and they're pretty functional. They're pretty active. They can zip around, right, real quick. They can, zip around as fast as you walk. Now, some of these lightweight or ultra lightweight chairs do have the option to add on power assist. That would power assist typically gives more oomph or more power for each propulsion. Okay, so where a regular propulsion might give them 5 feet, the add-on power assist might give them 10. Right, so it's good for people that are younger, in pretty good condition, strong arms. Yeah.
One has a power assist.
Uh-huh.
It's really cool.
Yeah. Okay, so now these are dependent manual wheelchairs, okay? So these dependent because this is something that a caregiver would need to push them in, right? They're typically not propelling themselves in this. So we have the tilt in space and the recline. Okay, a tilt in space is shown on the left. You'll see it's at an angle. Now, these typically maneuver, they are big, but they typically maneuver really smooth. Those back wheels typically roll really nicely. And basically, what the person pushing the chair needs to do is just, you walk to where you want, you stop it, you put the brakes on. Once the brakes are on, it allows you to tilt them back. Okay. Why do you think tilting back would be beneficial?
Pressure.
Get that? Yeah. So pressure redistribution for sure. What else? Sure. Yep. Yeah. So precautions. I mean, it could be, surgical related. That could be respiratory function, right? Maybe even digestion. Um, okay. Then there's the recline back. Okay. Same kind of benefits from that, relieving pressure. There's the respiratory and digestion that, component to that. But basically, with the recline, just the back is reclining. Okay. Whereas you'll see on the left for the tilt in space, their body positioning does not change, right? It's just the wheelchair is just tilting. Okay. They're still at 90 degrees there at their hips and knees. Whereas the recline really extends them backward. All right. All right, so scooters. So scooters can have 3 or 4 wheels. Okay, now a scooter is when their feet are resting on that base plate. Okay. Um, Now, because scooters have a longer base than a power wheelchair, they typically are more difficult to maneuver. So they're not really that easy to turn. Their turning radius is a little bulky. Um, so insurance coverage is difficult because they're really not that functional in homes because of their size. For insurances that do cover a scooter, they typically require them to be used in home um, because they typically are not good in the elements. Okay, rain, all of that. Um, so there are bariatric options for these as well, but the client needs gross and fine motor strength and coordination to use these, right? To navigate, where they're going, right? Gross motor, fine motor for the buttons. And this is not, um, it's not intended for long-term use, okay? Okay, so basic power wheelchairs, okay? So these typically have the captain seat, that standard seat, um, a standard joystick, on off button, speed control, flip back armrests, single foot plate, a lever for a slight recline. They're typically, for the most part, maneuverable in smaller spaces, but they might get stuck in, terrain, carpet, thresholds. Okay, so basic power wheelchairs are recommended for people with non-progressive, non-neurological diagnoses. Okay, um, people that have difficulty ambulating and the inability to self-propel a manual wheelchair. So then there are power wheelchairs. Okay, complex power wheelchairs. So for a complex power wheelchair, there's different drive configurations. Um, so whether it's front versus mid versus rear wheel drive, um, it all that is totally ATP territory. But basically, depending on the drive, that depends on the terrain you intend to use it in, right? And the turning radius that you need. But complex power wheelchairs can have a lot of different power options. So tilt recline, anterior tilt, leg elevation, seat elevation, some even transition to standing. Um, so there are a bunch of different features that some of you may have seen these. Um, Different control options, sip and puff wheelchairs. Have you ever seen those? Yeah, and yeah, head or chin controls for the wheelchair user to navigate, different switches, accessories. So, I mean, cup holders, rear view mirrors, flags, oxygen holders, tablet holders. Okay, so of course, a complex power wheelchair is, recommended for someone with complex needs, right? Someone with a long term disability, significant and serious neurological impairment, progressive disease. All right, so cushions. So for cushions for wheelchairs, there's a huge variety. So there's foam, there's gel, there's air, and there's hybrid. We'll talk about those. Um, they can be used for pressure relief, positioning, or both. Okay. Um, as far as positioning goes, this one on the right hand side is like a pummel cushion. Okay. The purpose of that is to keep the legs abducted, and also to improve like alignment of the hips. Also prevent someone from sliding forward. Insurance coverage of the cushions relies on the diagnosis and whether or not they have a history of skin breakdown. So foam cushions, let me see.
Why would that matter? Skin breakdown.
Yeah, they had a history of it.
Like pressure ulcers and stuff like that. If you sit too long on certain surfaces, pressure wounds and stuff like that.
All right, so here's an example of a foam cushion if you want to pass that around, okay? So the pros of a foam cushion, pretty low cost, okay? Insurances usually don't have a problem covering that. Negatives with that, it can be hot, okay? Not comfortable for sitting on a super long time. It can be damaged by moisture or light, not easy to clean it. Sometimes you see people with like, those egg crate that like some people line their mattresses with. People will like sit on those. Like those are like a total no in nursing homes usually just because of the germs, the bacteria, like you can't wash that out. So foam cushions are kind of like going away. I would say more often than not now you're going to see at least a gel cushion. So gel.
There's a Kansas City Chiefs one that is the same storyline.
Have you ever felt the purple pillow, the purple texture?
Oh, yeah. I mean, I know what you're talking
Like
about.
I have the purple pillow, I have a purple bed.
Yeah.
Yeah, have you ever felt the cone, those little like squares though? It's like the texture of it. I should bring my pillow in so you guys feel
No.
the texture of it. It's cool. It's a different type of. It's different. It's like gel, but it's not. It's not. It's like a silicone kind of squishy gel type substance, but it's not filled with anything. It's just filled with air. It's all like a honeycomb design.
Okay.
I don't know.
So gel cushions, I know we have them floating around, but they're not in here, of course. But gel cushions are nice because they are cooler in the summer. They can be cleaned easily, sanitized, whatever. But of course, they can be cold in the winter. They're also pretty heavy, and they can also be punctured, ripped. Don't last forever. Air cushions, you'll see these used a lot of time like in nursing homes. I feel like these are most often put behind their back, but very lightweight, easily clean, adjustable, right? You can pump more air into them to make them more taut, vice versa. Here is here's an example of an expensive air cushion. This is the Roho. There's a bunch of different Rohos. Basically, it's all these different chambers can be adjusted. So if you want to feel that. So of course, the Roho is super expensive, but that can be punctured too. But that's definitely like by far the most comfortable for long-term 24/7 wheelchair users. And then hybrid cushions, okay? Hybrid is basically a combination, okay? So there's foam and gel, foam and air. Ooh, this one is a hybrid. This is a weird one. Huh. Interesting. This is so interesting. This is like, oh, it's probably an old one. Yeah, this is just, I mean, not as soft as I was anticipating there.
Maybe it's just dry and old.
Yeah, that's what it seems like. That's so odd.
Weird.
They're usually so soft and squishy. So as far as hybrid, the pros and cons are the same as we've discussed with the others. A cushion with foam is usually harder to clean. Cushion with gel is typically heavy. All right, so custom cushions are a thing. Typically, in order for that to be done, the seating and mobility specialist would do pressure mapping. Okay, so the pressure mapping system looks at pressure distribution under bony prominences. Okay, so they basically sit on that pad, have them weight shift, and see areas of concern. All right, so other cushions or positioning devices you may see. Padded armrests on the left-hand side there. Lateral supports, right, which keep their trunk aligned. Also, there's like this comfort seat overlay. Sometimes they're called comfy cozies. They have different names for them. But good for someone that doesn't necessarily have the best upright position in the wheelchair, just to prevent skin breakdown. Wedge cushion, okay? So this helps with posture and also reduces sliding forward, okay? Usually you're gonna have the lower portion of the wedge where their butt is, okay? Also a calf panel or calf board, those keep a patient's leg supported on the leg rest, right? You might see that their feet tend to slide off, right? You don't want their foot to get caught in one of the front casters, which, by the way, the front wheels on a wheelchair are called casters.
Every time she wants to get off of there, they have to take that blue thing off.
Yeah, they do. It can be a pain, I know, but at the same time, it's like better than fixing their feet 30 times a day, So backrests, just like cushions, there's a large variety, and they come in the same with the same materials. Low versus high back, contour versus swing away, lateral supports. On a regular wheelchair, like the manual wheelchair, the backrests, they can stretch or become less taut over time, right? I'm sure you've seen that, right? Where it's just worn out. And it causes the patient to kind of have like a kyphosis, right? If the patient can't get a new chair, right, to have a more supportive backrest, they might benefit from, some sort of positioning device to compensate. All right. So pressure relief allows oxygen and blood flow to the tissues under bony prominences. Okay. So what are some bony prominences that might be of concern? Yep. What do you think? Anything bony where you might see skin breakdown for someone sitting in a wheelchair? Huh? It could be. Sure, it's not bony, but sure, there could definitely be irritation there. Yeah, so definitely the tailbone, okay? The sacrum, okay? Or I'm sorry, like the iliac crest. Ankles, elbows for sure. Even head, like the back of the head, ears. Who is at risk? Who do you think's at risk? Yeah, so clients who are unable to reposition themselves, right? Clients with poor nutrition, fragile skin in general.
Very bad pressure ulcers, like tunneling pressure ulcers. So bony. There's nothing to them.
Yep. So as far as pressure relief goes, there's no consistent guidelines. Some places may suggest that the patient is repositioned every 30 minutes, lay on the opposite side every 30 minutes for 5 minutes, right? It varies patient to patient. As far as options for pressure relief, power wheelchair positioning, right, which may help the patient be able to reposition themselves independently. Leaning side to side, leaning forward, or wheelchair push-ups, right? So you're sitting in the chair and you're kind of pushing up on the armrest to kind of get pressure off your butt. Okay. So when it comes to training someone and how to use their mobility device, their wheeled mobility device, storage is important. Transferring in and out, maneuvering it, right? Turning it on, turning it off, reaction time, integrating the chair into your daily routines, or, if you are in the patient's natural environment, working with them in their home, right? Going through the motions of their day to day while in their chair. Also, discussing any thresholds or ramps, right? Thresholds could certainly be barriers to a power chair. And independent versus assisted transportation. We're going to talk more about that on Wednesday.
A threshold is that little step that goes in?
Yeah. Also, you want to make sure that they're able to charge the battery, right? That they know. You wouldn't believe how many patients, you would hope, right? The wheelchair is delivered to their home, that they know how to charge it, but you'd be surprised. So yeah, battery maintenance, what to do if the battery is totally shot, right? Hello, Miss Hoyer, right? Sometimes they just crap out over time. General safety hazards. All right, so common problems and solutions. Client sliding out of the chair, okay? So if someone is sliding out of the chair constantly, you want to really, first and foremost, consider, is this chair even the appropriate size for them, right? Is the seat deep enough? Is it tall enough? Or, is it too tall, right? Or, I personally would probably fall out of a chair that was maybe fitted to Tegan, right? Right? Like more depth in the seat because of someone with longer legs, right? And a little bit taller, I'd be screwed, right? I would constantly have, a posterior pelvic tilt trying to shuffle around because I want to try to get my feet to touch the ground, right? Improperly fitted leg rests. Are they too high? Are they too low? These can usually be adjusted with those little pins, the same kind of pins that are in walkers, or an Allen wrench. Do a lot of adjusting of leg rests in nursing homes for sure. Legs falling out to the sides. So does the patient need support, right? Like lateral support at the thighs? Do they need maybe one of those calf panels that I showed before, right? To keep their foot from slipping off the leg rest. Now, what if you have a client leaning to one side constantly? Maybe consider one of those lateral supports, okay? For those of you that do end up, you're all gonna have 2 different fieldwork placements, but I would say the most of you will have a nursing home or adult experience, and you will likely see all of these issues and hopefully be able to help with all of the solutions. Headrest seems too high. Those can always be adjusted as well. This would be more for a power chair. Joystick cannot easily be accessed. Power wheelchair won't drive. Power wheelchair drives too slowly. There are just some issues that you would just want to call the vendor, right? Oh, it is on. Okay, perfect. I just thought I lost slides, but it's on your PowerPoint, so I'm happy about that. Okay, so power wheelchair for transportation of wheelchairs, right? There's lifts, trailers. There's ramped vehicles with tie downs. You can consider like the bus system that accommodates power chairs, taxis, van services. One thing that I wanted to go over was ADA. How many slides is that? 36, 37?
36.
Okay. Okay, so ADA, I added this on last minute because I thought it was important. So ADA, so states do not legally require home ramps to follow ADA standards because ADA applies to public accommodations, right? Schools, libraries, things like that. However, the following guidelines are strongly recommended for safety. So 1 to 12 slope. So for every inch of threshold rise, the ramp must be at least 12 inches long. Okay. So a 4-inch step would require a 4-foot ramp. Okay. So when you go up to someone's house and you see the obnoxious, right, zigzag ramp, right? There's a reason for that, right? That is probably ADA. Also, 36-inch width with bilateral handrails is also typically
So if it had 3 4-inch steps, then it has to be 12 feet long.
Well, if you
Is
had
that
three
how- no,
4-inch
no.
steps, you would. It sounds like
How's that work?
if they're separate, it would have to be 4 feet, a landing. You know what I'm saying?
Right.
Yeah.
My grandpa made all of theirs.
Yeah.
And
You don't know if they're. Yeah.
there's no handrails.
Uh huh.
They go into the garage.
Yeah. And I mean, teach their own. You know, people could certainly make their own, but you know, if you want something that's going to kind of withstand the elements, right? There are companies locally that do it. The VA provides them for veterans. Yeah. So 1 to 12 slope. Okay, so 1 inch to 12 inch. Okay, so 1 inch of threshold height. You need a foot long ramp. Okay, so there's an example of that.
1 inch of threshold height.
Mm-hmm.
It needs a foot.
Mm-hmm. 4 feet.
Right. So that's why I'm saying if there was 3 steps and they're all 4 inches,
Mm-hmm.
then it would be a 12-foot ramp. Correct?
Mhm.
Okay. Okay.
Mhm.
Because I just wanted to make sure I was doing that right. And it was like,
Oh, I thought you meant 3 steps and then another part of the house, 3
No,
steps.
just like-
okay.
if that thing right there was supposed to be 3 steps and instead they put the ramp
Well, you
in.
wouldn't measure it by step. You would measure the threshold in general, right?
Right.
Because steps aren't necessarily some homes, you know.
Well,
they
you're
could have a
talking
2-inch
4-inch
step.
steps. You're talking 4-inch step. What were you talking about 4-inch steps then?
It was an example.
Oh, okay. All right.
Everyone get it? Okay. All right. Michelle will probably be here at 3:30. I know she tries to get here at around that time.